This is QD Clinic. It's Lupus QD Clinic. This whole month we'll be having QD clinics and cases of interest that pertain to lupus. I'm Jack Cush with Room Now. Today's case is the curious darkening of skin. So it's a 30-year-old Indian woman who's had lupus for about 5 years, and her lupus was documented and manifest as malar rash, serositis, polyarthritis, alopecia, CNS lupus, class 3 and 4 glomerulonephritis, hypocomplementemia, lupus profundus, leukopenia, lymphopenia, positive ANA, double-stranded DNA, SM, RNP, and painless oral ulcers. Overwhelmingly lupus. She's been managed with chloroquine. The doctor that she was seeing prior to me had treated her with chloroquine and Cellcept and 5 to 10 milligrams of prednisone. And on the day that I see her, this is like second or third visit, I see her. She's doing well, but she has some GI complaints, and she is having some darkening of the skin on her arms and her legs, especially, somewhat about her toenails periungally. And she wants to know what she can do about this. So I send her to the dermatologist knowing what the problem is, and her chloroquine is discontinued because she has chloroquine-induced chrysiasis. Chrysiasis is a skin finding where there's hyperpigmentation, usually in a bluish gray, slate gray, sometimes grayish purple looking skin, depending on whether it's on white skin or darker skin. It can be seen on the extremities, especially in sun-exposed areas. That's like the key. It can be seen in the cornea. It can be seen on the eyelids. It can be seen periungally. And chrysiasis has classically been described in association with gold salt injections for arthritis. It began back in the 40s when gold salts were being used in heavy doses to treat tuberculosis. And you would get this slate blue-gray skin changes, mostly on sun-exposed areas when it wasn't found in the cornea, in the eye. So the question is, what can you do about it? Again, it's an uncommon thing. It's much more common with gold than it is with antimalarials. It's been described more so with chloroquine than hydroxychloroquine, or in this case, Adabrin, because the dermatologist changed her to Adabrin, also called quinacrine. And I don't know that I believe that that's going to be making it any better. The problem with this, it's a pigmentary change and it's permanent. It doesn't go away. And that's sort of the sad part. Sun exposed, permanent, the distribution, and there's not much you can do about it other than discontinue the drug and ask the patient to avoid sun exposure on especially the areas where they have this pigmentary change. This patient over the years since has noted a fading, even though she's been on quinacrine, a replacement antimalarial, for years. And this therapy in her started back over 10 years ago. And so she's not currently on a biologic. Her therapy is steroids, mycophenolate, and 2,500 milligrams of mycophenolate, and her renal disease has been kept in check. So that's today's case, pigmentation due to chrysiasis. Tune in for more Lupus QD clinics.